You're listening to PPRN, motherfucker.
PPRNradio.net.
I caught you knocking at my cellar door.
Check.
I love you, baby. Can I have some more? Ooh, the damage done.
Want to play like that? You want to play the whole song?
I hit the city and I lost
Hey.
my band.
Great song. I love that song, right? So this is Marc Bono checking in with you on open source recovery. And last week was our first show, and I believe I forgot to even introduce myself.
Probably.
Yeah. So I'm going to do that now. My name is Dr. Marc Bono. I'm an addiction psychologist and part owner of the practice in Madison called the Center for Compassionate Recovery. And I'm going to do a shameless plug for a minute here, and then we'll move on. So the Center for Compassionate Recovery is a small private practice that focuses almost exclusively on opiate addiction. And we have medicated assisted therapy, basically Suboxone, combined with individual and group psychotherapy provided by yours truly and some other licensed clinicians to be named later. And we have a real collaborative approach going between our medical staff and our therapy staff, and we're also able to integrate treatment for your addiction and mental health issues. And maybe most importantly, our practice is focused on a compassionate and empathetic and genuine approach to treating addiction, and we treat all our clients with dignity and respect, and we have a strong value system around that. And for some of you, maybe the most important thing is we accept state insurance, which is pretty unusual. Okay, shameless plug over. let me introduce you to our co-hosts, or let them introduce them to you.
When?
That didn't go very well.
Yeah, I don't know. Don't hear me either.
Oh, we didn't hear you, Lynn?
I don't know Alicia either.
Yeah. Well, I heard you, Lynn.
Oh, you did?
Yeah.
I didn't.
There we go.
There
She's
you go.
There she goes. And that's Alicia.
That's because Pete's not driving his green, sassy car.
Is that what it takes? Yeah. Okay. All right. So, what did you guys think about last week's show?
I thought it was awesome.
It was pretty powerful stuff. I'll say it again, Ismarie was very brave to come on and speak, and I was really touched by her courage and her story and her husband's story. And I think, I don't know if you guys realize this. I don't think I got a chance to tell you, Alicia, and Lynn, you just heard this, but that story was so powerful. I think it got passed around quite a bit on the internet, and we had a lot more listeners than we've ever had before. So, yeah, that story is out there now, and I know that's what Marie wanted. So, and I'm going to actually contact her and ask her if she wants to come speak to some of my groups and hear her husband's story, and I think kind of keep it fresh and keep it real for the people who've been in my groups and have been clean for 14 months. I don't want them to forget what can happen.
Right, exactly. That's a major thing.
So tonight's topic, we don't have a guest per se here tonight, but we do have a topic, and I think it's obviously a critical one. I want to speak about the opiate epidemic that's going on and the national health crisis that's just been officially announced, right?
Right.
By our fearless leader, Mr. Trump.
Yeah.
Yep.
Yeah, Alicia just told me earlier that he had figured out how he was going to stop the opiate epidemic, right, Alicia?
Yeah, go ahead.
No, I hadn't heard this, but no, your news, you tell it.
By enforcing better border control.
Yes.
Yeah, so.
No, that has nothing to do with it.
That's-
It does, but it doesn't.
Right.
Yeah, I can't with him.
Yeah, so there's an opiate epidemic, and it's not going away. bottom line, I don't care how high a wall we build in Mexico, the opiate epidemic is not going away. And it's obviously really bad in the Northeast, and we're smack dab in the middle of it. I could spew out a bunch of statistics about how many people have overdosed, and it's a lot, and it's almost doubling every year. And we could talk about why, but the bottom line is, as I said last week, I think we do look at the crisis based on number of deaths, but the reality is for every for every death there's X number of thousands of people who are suffering greatly out there, and the death toll is probably representative of the increase of the overall population who are suffering from opiate addiction.
Right. But isn't the problem too now, because it's so bad that these doctors are now taking these people off the medications, so their next route is to go to illegal drugs?
Well, I think you're talking about what the history is here. What's the trajectory of this epidemic? And I have some background I can share quickly. So I don't know exactly how long it was, maybe 10 years ago or less. There was the JACO who accredits hospitals. It's joint accreditation. I can't remember anymore, back from my days of being an administrator. But they accredit hospitals, and the hospitals really are dictated by those regulations. And so JACO came in and said that if you fail to treat pain, your hospital could get fined $10,000 per episode. And so what hospital staff started doing was, anytime someone said they had pain, they treated it, right?
Right.
And they gave out opiates in liberally.
They made it one of the vital.
Yes.
Yeah.
Yes, that's right. Can you expand on that a little, just so everyone understands what you're talking about, Alicia?
How it's one of the questions they ask now, just like with blood pressure and everything. It's like one of the vital sign
so when
points.
You go, right, and I've actually experienced this. I've gone into my doctor's office, and the nurse takes your blood pressure and your temperature, and then she asks me what my pain level is, and I'm and I'm not there with the pain issue, but she has to ask because it's one of the vitals, right? So anyway, so that started an explosion of people getting access to and then becoming addicted to prescription pain medications.
Right.
And some of those pain medications became more and more potent. The 80 milligram
Purdue Pharma,
the Panas and all that. Yeah. And then they started changing the formula to make those medications a little harder to abuse, and some of the more really potent ones were taken off the market. And slowly but surely, the price on the street for those medications started to increase, and that is what directly led to the heroin epidemic.
Yeah. I started using on Oxy 80s, and I remember it was $1 per milligram for that. And like everybody else, then you start to go to heroin because
it's cheaper.
Come on now.
Yeah. If you're doing 3 80s a day,
forget about it.
You can't. Who can afford that, right?
Well, but but my addiction ended up leading to spending that much.
Right.
You know what I mean?
Well,
that's besides the point.
Yeah, no, but it's a good point because this is the age-old story. So someone gets addicted to pills, they get the milligrams go up in terms of their tolerance level, and they have to keep paying more and more, and then they can't afford it. And so then they switch over to heroin because someone says, "Hey, look, for $25, this you could get,
right.
get right." And that's what happens. But then 6 months later, they're back in the same boat because they climb the ladder again. But for a short while, there's a reprieve there, and you're desperate, and you're out of medicine, you're in withdrawal, you don't have the money, and it's a trap. So that's what happens. So that's a very, common, in my practice, that's the most common thing that I hear is initial prescription pain pill prescription addiction. And I would say probably 75% of the time, it's not recreational use at first. It's prescription medication. Yes, that becomes sort of used recreationally, but it wasn't that someone was making a conscious decision to get opiates
Right.
for recreational use, and then it turns into an addiction. Now that does happen, of course.
That happened to me.
Yeah, and that generally happens with
Yeah.
younger people.
Yeah.
The younger you are, the more likely that is to happen.
Yeah, and when I started, I mean, that was when they were prescribing oxys, a lot. So it was flooding, the streets and everything. It was just so readily available.
Right.
You know.
And now I think it's more that the heroin is more readily available.
Exactly.
Than,
Oh, yeah.
than
Yep.
even pills
out
because
of
now,
control.
because one of the responses I'd like to talk about the opiate epidemic and the response by our government and and in Connecticut in particular. So part of the response, which makes sense, has been targeting prescription practices. So for instance, many states, including Connecticut, have passed a law that an initial prescription for pain for opiates can't exceed 7 days. Now that's the initial one. So that means you don't break your wrist and leave your doctor's office with 120
Right.
per 30s, right? So that's it. You're done if you
Right.
So that that makes sense. There are some other things that make good sense too in terms of prescriptions. There's there is a requirement for the doctors to check this central registry to make sure people aren't doctor shopping, right?
Right, yeah, because I was a pharmacy tech, and when I was working in the
Yeah.
pharmacy,
Yeah.
it comes up. Once you put that person's name in, and if they've had it,
Yeah.
it comes up and tells them the last time they actually were prescribed them.
Right.
And then if it's in with the days, and then we can't subscribe it. You can't. They can't get it. That's what I
Yeah.
saw.
So that in the technology that we have today, that's a no-brainer, right?
Right.
So
Right.
people should be protected from themselves in that way. So that makes perfect sense. Those are some things that we've done. And then the other big thing that you hear about is Narcan, making Narcan available to everyone, so
Yeah.
that people who are on the edge could be brought back. Again, that there's no one that would argue that that's a bad thing. That's a great thing, actually. But
Well, there are people that
Abuse it.
Well, no. There are people that will argue that.
really, that
I mean-
people with people who are dying from overdose should not be saved with Narcan.
I wouldn't argue that, but there are people
Well,
arguing that
if
it
the-
should be limited. And
If there are those people arguing, those people are not. We're not going to discuss those.
yeah,
exactly.
that's a whole other
I'm
subject.
up for looking at things from a different perspective.
Yeah, that's
but
a whole
Right.
other subject.
That's
But they,
not debatable.
they do. There are pharmacies now that you could grab it without a prescription,
Right.
and
It's getting easier and easier to
Yeah,
obtain.
yes,
More
yes.
all the first responders are having it, and what's happening too, is to go on a related side note is, the heroin is no longer just heroin, right? So
Right.
Right.
the fentanyl era is here,
Right.
and this is why one of the reasons why people are dying from overdose. And the reality is they're not really dying from overdose. Technically, on the death certificate, it says overdose, but accidental overdose is usually what it says. But really what's happened is that person was poisoned. And what I mean by that, the difference between overdose and being poisoned is pretty simple. If you're a heroin addict and you're snorting or shooting 2 bundles of heroin per day, and you decide that you're going to just get just today is this day. You're going to test the limits,
wasted.
and you're going to do a 3-bundle day.
Yeah.
And you overdose and you die. That's called an accidental overdose, right?
Right.
Accidental or not. Now, if you're a heroin addict and you're doing 2 bundles a day, and you do on your second bag of your first bundle, right? A bundle is 10 bags. If you're doing your second bag and all of a sudden you turn blue and drop and have to be resuscitated, or you don't make it, if you die from that is a poisoning because you weren't nowhere near your normal limits of tolerance, but you died anyway because someone put
Put the
fentanyl in a percentage that was fatal.
or carfentanil.
Or carfentanil, or any other fentanyl, all the fentanyls. But you see what I'm saying? Like, so in some ways, I really don't look at that as an overdose as much as a poison. So a lot of people are being poisoned because they're doing something that's dangerous. But it's that poisoning that's making the overdose numbers skyrocket.
Right. Yeah, I've seen
Okay?
it, unfortunately.
And I don't know who was telling me, but one of my clients was telling me that there's a place up in Hartford that does and it's a needle exchange program. I don't know if
Right.
you're familiar with this.
Yeah, I've heard of them.
I don't know. Was it you telling me this, Alicia? I can't remember. There was someone telling me that they test heroin off the street up there.
To make sure that there's no...
To see if there's fentanyl, and they've gotten bags from all over Hartford, all over New Haven, and most recently, there were no bags that didn't have fentanyl in it. They all have fentanyl in it, and I can back that up because anytime a client of mine comes in that's new or someone that has a slip up, and they admit to us that they've done heroin, and we get the lab results back, it has fentanyl in it.
Yeah.
Every time. So you're playing with fire because you're using a substance that's 10,000 times stronger than,
what your body's used to.
Well,
too, and it's not.
than heroin. So
Yeah.
a little bit too much, and that's it. That's all it takes.
Isn't that why, too? Because, unfortunately, I had a friend pass away back in May, and now they're going to try to start going after the drug dealers.
They are, because it is being looked at as a murder.
Right.
Yeah, they're doing that a lot now.
Which
Yeah.
I applaud it. I applaud it because especially if they know it, especially if they know that's what's in it, and they're selling it to you.
Well, I don't
Someone trying to call in, Pete?
think they know.
Okay.
You don't.
You're live on PPRN.
Yeah, we got a call.
Hello.
Hello.
How are you?
Good. Who are we speaking to?
My name is Jen.
Hi, Jen.
Hey, Jen.
How are you? Hey, how are you?
What can we do for you? You have something on your mind?
Yeah, a lot of things actually. Let's see. Where do we start? What are you guys talking about tonight?
We were talking about the opiate epidemic.
Okay. Yeah. Has anybody considered the reason why people go to the opioid? I.e. the crack, the coke, the heroin, everything else like that, just because they can't get the psychiatric medications that they need?
Sure, that's a whole related topic. That's actually my area of expertise is called co-occurring disorders, and when people who have mental health issues don't have access.
Like me.
Okay.
Like me.
Okay.
I'm bipolar.
Bipolar.
I'm bipolar.
Okay. And have you substituted others like street drugs for your mood stabilizers, or have you used when your symptoms were kind of out of control because you didn't have medication?
No, I've substituted just because they weren't given.
Okay.
Let's see. You go to one doctor, especially being on. You go from having a job with good insurance to having no job, so you have to go on Husky.
Right.
And so you have to wait almost a year to get into a psychiatric APRN, I would say. And even then, they prescribe you what you weren't prescribed before, but they prescribe you crap. Like, I was prescribed 2 medications, and then now I'm on 12. So, but none of them were covered what I was on before that helped me.
It sounds like you need better care.
Exactly. Well, thank you, Husky. There you
Well-
go. Thank you, Blumenthal.
Well, I one of the reasons I started my practice, Jen, was because I was tired of seeing people with state insurance not get the quality care that other people were getting. So the vision I had in my practice was, can we provide really high quality care for for people with opiate addiction, and regardless of what kind of insurance they have, and that's basically my model. So as far as you're getting help for your psychiatric needs with Husky, if you want to, I can try to help you find a resource, because I'm forced to do that all the time because I have clients who need mental health treatment. And sometimes it's a struggle, but since most of my clients have Husky, I've formed some relationships with good providers who take Husky, and it certainly doesn't take a year to get in to see them.
Okay, because for me personally, I had to go to alcohol to downplay
Right.
like what my Klonopin would have done. So as opposed to get my Klonopin prescription, I drank. And long story short, I ended up in a detox facility. And listening to, I was in one which housed 19 people, and me, I'm 43 years old, and this was just a little over a year and a half ago. All these kids, and I'm talking kids like in their early 20s, hearing their horror stories. They're kicked out by their parents because they're on these they're on drugs, or they're gay, or the parents don't accept their lifestyle, things like that. There's nobody to help these kids, and so they end up on the street, and they end up doing whatever they have to do, and that's, you want to block out what you have to do to make it, and that's the drugs.
Yeah, unfortunately, that's another whole issue of, and there's a lot of media attention on this lately. There are even younger kids out there who are not, huge groups of them who are out on the street because of their sexual orientation, sexual identity, things like that. Hey, Pete, bless you.
Bless you.
And whose families are not supportive or accepting of that. And so those individuals are out there on the street, and then they become vulnerable, and they wind up addicted.
And that's the part that, like, it saddens me, because we can't help these people. I mean, they're people too, and we can't help them. And that's the part that's like, they want help. They're actually they're going to the hospitals. They're going to the rehab centers. They're asking if there's beds available, and there's nothing there. And that's the part that, I know Blumenthal's trying to do it, but, Malloy needs to step up his game. Everybody else needs to, do what they got to do to help these people. They all, talk about it. Well, let's see results.
Yeah, before you got on the line, I was just talking about the opiate epidemic and some of the things that are being done to help, including use of Narcan to prevent deaths and prescription laws.
Yeah, they give Narcan out for free, but
right.
What about cancer patients? Don't get me on that subject.
No, but hear me.
Narcan's not free.
Hear me out. Hear me out, Jen. What we're talking about, though, is that what there isn't a big focus on is the quality or the quantity of treatment. That's what we're going to get into today. Well, there's not nothing, but it's not enough. And some of what is out there is not good enough. And we're going to talk about that. So if you want, I'm going to give you my cell phone number if you want to call me anytime after the show, and I can help you out. Okay.
Okay.
All right. So here you go. You ready? 203.
Give me a sec.
All right. Yeah. No. Take your time.
Figure out how to do this.
I got it.
I'm old. So
You're not old. I'm older than you.
old.
I'm older than you. So don't say that.
You're all old.
Stop it.
She can say that.
You know what? Give it to Alicia. I'll get it, and then we'll go from there. I'll get it from somewhere.
Okay. Alicia has it. So absolutely.
Thank you, Dr. Bono. I appreciate it. I appreciate you listening to me.
Absolutely.
But it's just a lot of us. We just don't have nowhere to go. That's what it is.
Well, you can come see me, and I'll help you. Okay.
All right. Thank you, Dr. Bono.
Okay. Take care.
Thank you.
Bye-bye.
All right. Have a good night.
Good night.
Bye.
All right. Well, that was an interesting perspective.
Yeah.
And she hit on a couple of big subjects. The whole issue about mental health, that's a whole other show, to be honest with you. and the other issue about all these lost kids who are out there on the street.
That's what they all end up in jail. Because unfortunately, when I was away too, the kids I was like the oldest in there, and I'm 42, and all of them. It was all from heroin. They're all there because of heroin, all of them. It was like, wow.
Yeah.
Unreal. It was unreal. They send them to jail first, and then they set them up with these programs. Then they're sitting in jail waiting for a bed or waiting to be sentenced.
Right, we're using.
and they're sick, and
Yep, it's bad.
yeah, and they don't even care in the jails. Believe me, they don't even care.
So one of the things I wanted to talk about tonight was the treatment aspect of the opiate epidemic. And honestly, I think that I think that the resources are going around treatment in some ways because I don't think people have a real belief in treatment as a real possibility of curing this epidemic or having a significant impact of the epidemic, and that's really a shame because it doesn't have to be that way, and it shouldn't be that way. So if I want to talk about the challenges of treating opiate addiction because it's a separate category. If you've had different kinds of addiction, if you've ever been addicted to opiates, it's a whole separate category. There are some parts of opiate addiction that really have to do with the physiological aspect of what happens when you get physically dependent on opiates, and the resilience of that physiological change that takes place. That creates a whole other track that you'll have to do opiate addiction on, and it means that you need to have medicated assisted therapy. It for 95% of the people, they can't just stop using opiates. They can't just stop. And Alicia's looking at me because I think she's one of those 5%. But if you go
I went to detox, so I mean I
okay
wasn't in treatment, but I've been on medication assisted treatment on and off for many years.
Right.
But obviously detox, I needed it because of that sickness, the physical part of it.
And most people, and if you were in detox, you probably met a lot of people who've been in detox over and over again.
Oh,
right?
I've been in detox over and over again.
So you got.
I was still detoxing after detox.
Right. Yeah, that's a whole other issue. I'd like to talk about that too, because we don't have a system of care that's set up to respect the physical component of opiate addiction. So the standard of care is medication assisted treatment. It's called MAT. The thing is that means medication assisted. Actually, it's not treatment; it's therapy. That's what it's called, medication assisted therapy, and that means that the medicine is there to assist the therapy. The medicine is not the treatment.
Right.
Okay.
Right,
the medicine
right.
gives you a fighting chance at getting into and benefiting from the treatment, the therapy. So the reality is, many places don't have any, the emphasis on the therapy is not there.
No,
Right.
not at all.
Yeah.
I've seen it.
I've seen that.
I've seen it too.
So if they want to enact laws, the standard of care is that if you're a physician and you're prescribing medication like Suboxone, that you should be doing that in conjunction with a therapist. But there's no law that says that. That's the standard of care, and many
So
physicians just
right,
ignore
they
that
just
standard
they're
of care.
writing scripts.
They're writing
That's all they're
scripts,
doing.
right.
Yeah.
And recently, one of the things they did to try to create more access to medication-assisted therapy is which I begged them not to do this. I talked to some politicians up in Connecticut, and I was advocating hard not to do this. They changed the limit from 100, which is what a physician used to have, a limit of 100 clients or patients that they could see and prescribe Suboxone or Suboxone or another Suboxone-like substance, and they changed that to 275.
Wow.
So how do you take care of that amount?
You
can't.
cannot. You
No.
can't. You can't.
So-
I think I figured it out that
That's crazy.
it's like you if you didn't use the restroom and you were at work 8 hours a day, you would have 4 minutes per patient or something for 40 hours.
Wow.
So it's just an absolutely horrible idea to expand access to treatment.
I mean, I understand why they were doing that
Yeah,
or the point
yeah.
of it, but yeah, there should be, like you
But-
were saying, some requirement that if you're going to be on this treatment, you have to have therapy along with it, whether at that office or somewhere
But
else.
the thing about having it not at that office is
I know.
So yeah,
Right.
the deal is like, right, my practice has somewhere between 50 and 70 clients. How would we coordinate with
I
50 to
know.
70 different physicians? So
I
it
know.
really has to be coordinated. It really does.
Yeah.
Because therapy is great, but if we're not interacting with the physicians, you lose a lot of the value.
What do you think about the stance on like what Portugal did and everything? Do you think that would help it?
Well, that's just decriminalizing it. What Portugal did was decriminalize all of their substances. There's no criminality around using heroin or cocaine or any of that kind of stuff. And what they were able to do is take the resources that they're spending on fighting the criminal nature of those substances, and put them back into things like helping people find jobs. Getting them treatment on demand.
Yeah, not building a bigger wall.
Right. And so there's what Portugal has determined is that they've reduced their substance use issue by about 50%.
Yeah.
Which is a huge.
That's a lot.
Kind of like a wall, ain't it?
like a half high wall. It's 50% of a wall. But no, that is that's a great model. I don't think our country is that progressive and ready to embrace something like that. We're stuck on the idea that that legal means okay, when certainly it does not. But
Legal means okay, but it's still coming into the country faster than anything.
Well, whether
it's ridiculous. Why don't we just call it what it is? It's money for them. They're making money because they're getting little handoffs on the side.
If you want to take money out of the drug dealers' pockets, no more cartels. You decriminalize the substance.
Exactly.
We tried that with prohibition, right? That's
how many jobs would it create too if you start making factories that produce the shit?
Yeah, right.
But
think about it. You got people rolling joints all day.
There is
like a cigarette company.
I don't remember which country though, but there is a country that you go in and they give you heroin to safely shoot.
In Switzerland,
Switzerland,
they have medical grade heroin,
yeah.
And people could go in and inject themselves.
But is the addiction because of the crap that's in it, and you're not getting it good all the time? Or is it the addiction of...
That makes it dangerous sometimes, but that's not the addiction. So in these I don't know what they call them in Switzerland, but in these
medieval times,
they're
like safe haven, safe shooting galleries,
whatever.
Yeah.
They don't have people
like
dying.
a hookah lounge.
They don't have people dying from overdose, and they don't have people getting infections. And
right.
Like that. So
look how clean Amsterdam is.
It's a harm reduction model. However, I'm involved in treatment that's a recovery-based model, and people can recover from opiate dependency. They can. And however, there you are. But it has to be done right, and it has to have all the elements that you're supposed to have, including therapy, including collaborative care, and you have to treat people like human beings and treat them with dignity. And you have to have the medication, because for most people they just can't stop and get on the right track without it.
Well, I think the other problem too is, at least the many treatment facilities I have been to, it's all the same. It's not really individualized.
Right.
Do you know what I mean? It's the same type of 12-step fellowship. It's the same.
It's a factory
right,
approach
yeah.
and you can't do that. And I think the worst possible the example of that is, I think, the methadone clinic.
Wow.
Literally, you're on a line like cattle, walking up to get the thing.
Yeah.
And I'll say something that some people might find controversial. I don't care. Nobody should be on methadone. And the reason nobody should be on methadone is we have this thing called Suboxone, and it's way better. And when you have someone, that the woman that called in, Jen, she was talking about cancer as an analogy. Well, I do use that analogy, saying, if you had cancer, you would not use medication that was developed in 1979, and that wasn't as safe and wasn't as effective and had more long-term side effects, and was delivered in a system developed in 1979. Sorry, that's not conducive to recovery. I don't care who you are. If you're standing online in a methadone clinic and you're staying clean, you're doing it despite the place that you're at, not because of the place that you're at. And Alicia, you've been to my office. Lane, you've been to my office.
Yeah.
You see that there's a place there where you can actually recover. And doing
And there's
that.
no line out the door.
I mean,
start at 5 o'clock in the morning.
Right.
Yeah, I
It's
mean,
just
I'm a multiple
crazy.
again. I'm a multiple pathways person.
Yeah, I know.
So, but that was one of the problems when I was on methadone. I just the environment. It didn't make me feel like I was in recovery. I still felt that stigma, like that junk. I didn't. It just didn't sit well with me. Which is one of the reasons it didn't work for me.
When someone comes into my practice, I introduce them in group to everyone, and everyone goes around and talks about what got them there, and then how they've been doing since they got to the Center for Compassion Recovery. And when you're sitting there in a group and you're hearing someone saying, "Oh, I've been here for 12 months and I have 11 months clean, and I've been here 14 months and I have 14 months clean, and I just bought my first house, and I'm
Right."
By the time that people are going around the room introducing themselves, you have hope.
That's
Right.
how when I went to your office, it was different than from what I've seen in my experience, again, with things like methadone and even Suboxone when I first tried that, in the beginning of my addiction. It was a different environment there.
And so the environment is critical. And
Huge.
And if you go to most places where people have state insurance, look at the environment and see what it looks like, it's not conducive to recovery.
No.
Nobody's going to say this is conducive to recovery.
No.
Not all of them. There are places that, but most of them, no.
Like
How
I
come-
was.
Oh, sorry.
That's all right. No, because unfortunately, like with me, I had 2 ex-boyfriends, and I used to bring them to the methadone place to go get it. And there's the people outside selling their Klonopins, their
Right.
Xanax,
Yep.
their this, their that. And it's like, how do they get clean if you got all these people? Nothing's being monitored outside the place
Right,
either.
right.
They're all standing in lines. It's like a hangout for them. I've seen that where they're just hanging around. I knew somebody that hung out there all day long.
Right.
And just, until they closed. And I was embarrassed being there because I had people, what are you doing here? What are you doing here? And I was like, well, it's not for me. And
you shouldn't have to feel that way if you're in and that's why Suboxone, one of the reasons that Suboxone was created and the laws passed so that people could go to a doctor's office and get a prescription like any other kind of treatment.
Why can't I heard they were trying to do this, but why can't you go to a doctor's office and get methadone?
Okay, so let's talk about that. Well, the reason that you can't get methadone is that all the laws and regulations from 1979, when methadone was first put out, and are still the same. They're exactly the same. They haven't budged at all. You could be pregnant and they want you on, and you could be 8.5 months pregnant, and if you're not standing on that line that morning, too bad. You're not getting your methadone.
Yeah.
And I've experienced that with pregnant clients. So the laws are archaic, and even if you could go, Alicia, even if you could go to the office and get methadone, why would you? Because if you look at methadone and you put it side by side with Suboxone, there's really no comparison.
No, you're right. Suboxone is better, but I remember, like I said, I started on Suboxone. Again, this was over 10 years ago.
Yeah.
I started on Suboxone. That was the first type of treatment I tried, and there came a point where it just wasn't working. Maybe this was just in my mind, and this is how I remember it now, because it was so many years later. It just wasn't working the same that it did the first few times I tried it. And I just ended up going to methadone, There was also insurance reasons, too.
Yeah, right.
Like, insurance wouldn't cover, this is probably different now, but at least at, down in New Haven, insurance wouldn't cover Suboxone, but it covered methadone. Because they
Right.
said Suboxone was a longer treatment than methadone.
Have they seen the methadone clinics?
I
Like,
know.
You
I
can't
know.
get out of there.
Again, this might be
No, they don't let
different
you.
now, but yeah, that back,
right.
then when I
Right.
tried to get on
Right.
it, there only select few were able to, and that was the reasoning.
And I remember I would ask my exes, why can't they bring you down? And they don't like to bring anybody down either. Lower their doses.
They make it very difficult.
Yeah,
in
it's
fact,
ridiculous.
In fact, honestly, the people who are solid on 60, they bring them up to 120, 130.
Yeah.
And that is a common practice now. They're really, in my mind, what you're doing is chemically imprisoning people.
Exactly.
They'll be lifetime customers. That is deplorable to me.
But-
and all my clients tell me that is their experience
Yeah.
when they were on methadone. Not every single one of them.
I seen it.
Yeah.
I seen it.
Yeah.
But now with the being incarcerated, they're changing it now too. They're making people get off. If they're in there longer than for so many years, they're making them get off. They're detoxing.
Well,
them
that's because
now.
they've just recently started giving people methadone in the prison, not
Right,
all of them.
right.
And they're not going to support, if they're going to be spending 10 years in prison, they're not going to support them on methadone for 10 years. So when it comes to cost savings in a prison, yeah, they'll make them get off it. But when it comes to profit outside the prison,
Right.
there's no incentive to get them off.
I've heard there were some prisons that before you would be let out, they give you a Vivitrol shot.
Yeah.
Because of overdose, and I
Yeah.
guess that's really common.
Yeah, that's there's nothing wrong with that. That's good practice.
Do they do Suboxone in jail?
No.
It's only methadone.
No.
Really?
Yeah.
I saw so many girls that were sick.
But
It was
Suboxone
unreal.
has become the number one illicit drug in prison.
Well, what about if you went in pregnant, or you methadone? They would just give you methadone, huh?
They would give you methadone.
Yeah.
So, on a side note, Suboxone is snuck into the prison system all the time now. It's because it's so easy to sneak in that people who are abusing opiates in prison are usually doing it with Suboxone, and we should talk about the stigma against Suboxone, because a lot of people have a bad opinion about Suboxone, and it's really because they don't have the right information.
For me, yeah, and it's still fairly new.
Well, it's not fairly new. It's been
Well,
out since 2003.
I was about to
So
say,
that's
when
not fair.
when I was on, it was right around then, and
Yeah.
it was the pills.
Yes,
Oh, they were
right.
disgusting.
Yeah.
See, I'm
The strips are no better from what I hear.
No, but the pill. Oh, yeah,
I
that was
didn't get
just
introduced to this
Yeah.
epidemic until like 2009.
Right. That's about when it started to really heat up. Yeah.
I heard they also have buprenorphine that they put it under your arm,
Yeah.
and it's slow release for
that's
6 months.
Right. There's a problem with that, though. Unfortunately, the company that makes that product, I can't remember the name of it. It's a great idea, but they have these restrictions around using it that make it almost really impossible to use. So you have, first of all, you have to be stabilized on 8 milligrams of Suboxone to use it. Okay, so that's one thing.
Right.
But the other thing is that you have to be considered stable on the medication. You can't be. And I don't know what the definition of stable is, but the people who need to have an insert put into their arm for time release over 6 months are the people who can't make an ongoing commitment to taking the medication.
Yes.
They're the
Yeah.
unstable ones.
Yeah.
So that just defeats the whole purpose of that.
Who knows though if that's
Yeah.
somewhat new.
It is somewhat new.
So
but
that could
I looked
change,
into it, but it just, I haven't found one client where that it would really help that client, but that client's always outside the parameters.
Yeah,
So,
because that's the problem. Suboxone only works if you take it, just like anything else. So,
right. But most people don't have a problem once they're committed to staying sober.
Right,
They're on
yeah.
the Suboxone.
Yeah.
So the reasons I think Suboxone has such a bad rap is Suboxone can be abused in a couple of ways. One,
like anything.
Right. Like this. You can
Methadone.
Of course.
Yeah.
Suboxone can be abused in a way where people who are trying to keep their addiction going, but they don't want to go into withdrawal, they have buy some Suboxone, and then in between, when they're going to get sick, they take the Suboxone until they can,
Get money or whatever
again,
it
or find more pills or heroin. So that's sort of an abuse of it. Of course, that's not through a prescription. That's for
Off the
buying it
street.
illicitly, right?
Yeah.
And then if you've not used opiates before, if you're not opiate dependent, and you take Suboxone, yes, you will definitely get high. In fact, people grossly underestimate how powerful Suboxone is, and they do something ridiculous like take an 8 milligram strip, and they're high for a week.
I've seen it. Yeah.
Yeah, it's not good. So, but the thing is that Suboxone was developed for people who have a pre-established desensitization to what they call full agonist opiates, right? So Suboxone is a partial agonist opiate, and because of that, once you've used a substance like heroin or fentanyl or oxys, your brain will not. There will be no euphoria associated with the taking of Suboxone, and therefore. The benefits of taking it is that it stops withdrawal and craving, but creates no euphoria. And so when you're in therapy and you're in treatment and you're in recovery, you still have to deal with everything that comes along in your life. You're not numbing it with Suboxone.
Right.
And people who say that you're high, you're not clean, you're not sober if you're on Suboxone, that it makes no sense to say a substance that's not mood altering makes you not clean. That makes no sense, because people who are taking it are not getting any euphoria from it.
Right.
And it doesn't matter how much you take, you get tired, but you're not going to get euphoric. So I think that if, for instance, in NA and AA, there's a big stigma against the use of Suboxone. And,
any type of medication.
Yeah, but in particular with opiates, especially in NA, there's a lot of people who can't be open about the fact that they're using Suboxone. And I just don't see how this stigma maintains when there aren't a huge group of people who are all getting clean without Suboxone. That's just not happened. That those groups of people are not out there. So what we're telling everyone is that you should be the 1 in 50 person that could just stop by yourself. Well, that's dangerous. It's a dangerous message to give to people. And when I first got in the field, that's when Prozac was becoming really popular, and it was being prescribed a lot, and people were being told by their sponsors or people in their network that they weren't clean if they were taking Prozac, and they were going off their medication, and in some cases wind up dying from suicide. So that's why AA and NA came out with that pamphlet that says we're not doctors.
I think Suboxone, though, doesn't really have that bad of a rap. I think methadone has a...
Oh, yeah.
Well,
of the two.
Yeah, but that's the thing. People lump those two together. They really do. People who don't know about the differences really see those two things as the same thing. They don't understand the differences, which are huge, between Suboxone and methadone. They really are. And people don't understand that. There's so let's do a quick side-by-side comparison, right? So methadone is a full agonist, which means you can get high on methadone. And
keep the party going.
And because it seems like the methadone clinics are really not stingy about the dosage, right?
No.
There's a lot of people out there who are pretty well loaded up and lit up on methadone.
Oh, yeah.
And on top of that, Suboxone you can't get euphoric, and methadone you can. Suboxone is a blocker, and it blocks the use of full agonist opiates. So if you try to get high on it, you will have minimal success or none, depending on how much Suboxone you're taking.
Doesn't let anybody else into the party.
No, parties walled off.
Doors closed.
It's completely over.
So, like, yellow police tape is around. No. Okay.
Yeah.
So there's that's a huge advantage. One of them is a blocker. The other one you can use right on top of.
Yeah.
I could do heroin
Yeah.
right? And now you're getting more high.
Yeah.
So that's kind of a big thing, right?
Yeah.
Now the thing about methadone, what you're doing is you're giving someone a synthetic narcotic who is identified as an opiate addict, and you're giving that person a substance that can get them high and telling them to take just the right amount.
Right.
Not too little so you'll be in withdrawal or craving, but not enough to be high. If they could do that, then they wouldn't need that.
You know what? So I was on I was on 30 milligrams, and that was enough for me. And they kept telling me, no, you need to go up because around 60, 70, that's when it's like a partial blocker or something. And I was like,
you're getting
what?
more high. You're getting high.
Yeah.
If 30
you're like, that's the magic number right there.
If 30 is enough, then 60 you're gonna be high.
The problem though, when I was on methadone, it made me want to use more. I felt like I said, this is the first time I haven't been on anything, and I'm actually, recovered for 2 years now. This first time, and I've noticed I haven't had cravings, whereas when I was on methadone, I had such bad cravings, insane, and at first when I first started, cocaine, I would use crack, and and it just, I don't know.
That's what I've noticed too.
Made my cravings worse.
On the heroin, they would go to the crack, and then when they were on the methadone, they were turning to crack, and it was
well, if you're on methadone, you're really heavily sedated, and you start doing crack, it becomes
because it picks you up.
Yeah, it becomes
because
this kind
they're so down.
This nice kind of combo thing where
it evens them out.
Yeah.
Okay, because I never understood that either. I was like, I don't understand. Why are you going to do that? And you really like to be.
Because you know what it is? I just wanted to get high, and not that I couldn't on methadone, I could, but I wasn't. I mean, I was craving, but I didn't need dope, and I was around. And one thing leads to another, and now I got multiple addictions.
Right? No, it just made you worse. Just like when the surgery, when my significant other, he had his surgery, he was on the methadone. They gave him the Dilaudins to go above and beyond it so it could deal with his pain. I was like, what is that? What is that? So you made him even 10 times worse now.
Yeah, well, pain, man.
Well, the Dilaudins will go over that.
Right,
and the morphine will go over that. So but why? He has an addiction. Why are you doing that?
Well, I don't know what kind of surgery he was having, but it can get real complicated if someone's going to have actual serious pain. And
it was. It was bad. It was bad surgery.
Sometimes there's not much of a choice.
But I knew it was. We knew that was it. That was the downfall. It was an automatically.
Well, that should be really carefully monitored afterwards and so forth.
That's what I said. They should have kept him in the hospital and weaned him off to make sure he didn't go out and
absolutely
go look for everything. They just he was not even a week. Okay, you're out both.
Yep.
We had a visiting nurse and she was noticing it.
Yeah.
And it was like, well, if you're noticing this, why aren't you doing something? What can you?
Yeah, and that's part of why there's an epidemic. There are a lot of prescribers or physicians and who really don't understand even the basics of opiate addiction. It's crazy. And so someone will load someone up and then all of a sudden they get nervous and say, oh, you've been taking this too long, you're cut off. You talk about setting someone up.
Yeah. Oh, it was a complete setup. That was the downfall.
Yeah.
That was it.
So I almost want to just quickly touch on so you know my stance on methadone, which is a big part of our treatment protocol here. And the other piece I want to talk about a little bit was detox, because what's happening is that people are going into detox for opiates and they're not being detoxed.
That's for sure.
That's for sure. So what's happening is they go in and they're given usually methadone, sometimes Suboxone. Either way, they're given a long-acting, synthetic opiate, and they're quickly brought down in dose. But because this is a long-acting substance, it builds up in your blood system. Mm-hmm. So you come in and you go on. If you're doing Suboxone, let's say they give you 12 milligrams, 8 milligrams, 4 milligrams, 2 milligrams, and they send you out. But you have a decent amount of Suboxone in your system, and you leave. And guess what happens 3 days later?
You're going to start.
Well, I have to say in the detoxes I've been to that have done Suboxone in comparison to the ones that have done methadone, the detox was much easier with the Suboxone ones as opposed to the methadone ones. The methadone, when I would get out, it was much harder.
Yeah, methadone is definitely harder in terms of detoxing from. Yeah. It's longer acting. It's a full agonist opiate. It's much harder. But either way,
you still feel like crap.
That's not detox. That's not detox.
You still feel like crap.
That's like I helped you wean down for a few days because you couldn't do it yourself.
Yeah.
But you're going to go back. 95% of the times, people who just leave detox without follow-up treatment immediately after, they go back. So we're sending people through detox over and over and over again and calling it detox, and it's not detox, and we're failing over and over again. And so by doing these kind of things, like using medication from 1979, and by putting people through treatment that we know doesn't work by itself, but we keep doing it as a standalone treatment, we're wasting valuable resources that we could be putting into good care and better treatment. And that's what I am frustrated with, is that nobody is talking about the quality of treatment. We're talking about prescribing practices and Narcan and all that good stuff. And there's good stuff, prevention and preventing people from dying. But what about treatment? What about the fact that our treatment, in a word, sucks?
Yeah. There is treatment, but it's not good enough.
There are some things I've seen. Some things that have gotten better. There's some residential programs that are letting people come in on Suboxone and staying, and then helping them as they leave. That's a big plus, because look what happened with Ismarie's husband. That's exactly the danger of having someone come in to a residential setting without Suboxone, who's been on Suboxone or other opiates, and they come in and they're withdrawing. And if you're on Suboxone and you go into a residential program and they take you off it, and you're in the program for a month, you're withdrawing for the first 3 weeks. You're not present. You're not benefiting. And then you leave, and you are nowhere close to being ready to be on the street. And then if you do relapse, your tolerance is down. So this is a very dangerous, clinical policy.
It's a dangerous game.
But it has been changing little by little. I've seen some programs, even large companies, start to change that rule and start to wake up to the fact that they can't just they call Suboxone a narcotic and say we're narcotic free, and causing people to go back out and relapse and die. So
yeah.
Well, but the other issue too is people going to detox and then not going for further treatment after the fact.
Yeah, that's my point, because that detox. What I would tell my clients that have been through that is if they were addicted to opiates and they need help. They don't need a few days of detox. They need at least outpatient treatment. So if they come to outpatient treatment, we do an induction
with medication assisted like yours.
Right. We put them,
especially
if
it's not in treatment.
That's right. We put them on Suboxone. We do an induction. We get them on Suboxone. Then they don't need to be in detox. There's no point to be in detox. It's futile.
I made sure this last time when I went to detox, I went straight to a program. And not only did I go straight to a program, but I had med cab bring me from point A to point B, because I knew if I did it myself, I wouldn't have never made it. I would have never made it.
Right. Yeah, and knowing that is knowing that doesn't happen like that all the time.
Yeah.
So if someone calls me from a detox, I always try to see them the day that they're being discharged, because I'll know they'll lose them.
Right. Exactly.
Because they're leaving detox in withdrawal.
Yeah.
Yeah.
So,
or leaving programs with no Suboxone doctor to fulfill what they've been on now.
Right. That's right. Yeah. So.
Yep.
That was fun, guys.
That was fun.
It's about that time already.
Yeah, already.
I can talk. I didn't even come close to covering all the issues, but I just want to wrap it up by saying we could do a lot better job of treating people with opiate addiction. And we're not using the science and the technology that we have, and we're not treating it as any other illness in terms of, making those kind of choices.
Yeah.
You guys want to say any last words?
Is it that the treatment isn't good because of the recipients getting it?
The treatment isn't good for multiple reasons.
Not about the clients.
No.
It's not about the clients. My clients are not. I didn't just pick 70 awesome clients. It's the program.
Maybe you did.
Well, that's a lot. That'd be pretty lucky.
Right.
That state insurance thing, that's the big thing. I'm telling you, that's the big thing.
The problem with treatment centers is, again, they're all, it's one little box, and you have to fit into that box. And if you don't, like inpatient, if you don't fit into this box, especially state-run
Emphasis
places.
on box.
Yeah, box. Then, again, they're all run the same exact way. They teach you the same things, and they don't know any better. And that's not how it is today.
No, treatment has to be individualized.
Yeah, and it's not. I mean,
No,
they're
not.
like, you need to do this and this, and
Right.
that's it. And they've been saying that for years, and they don't understand that today is different.
It's not about
Well,
today.
not just today, but
people are
we
different.
know more
People
today.
are individuals. People need to be screened for mental health issues. People need to be screened for trauma. People need to be screened in many, many different ways, and you need to have a relationship with them. Right?
Yeah, Pete.
Yeah, Pete.
Get it together, jeez.
Yeah, don't blame the clients, Pete.
Let's blame Trump.
Well, that's okay with me. I'm okay with that. Pete's okay. He's a Cowboy fan. Leave him alone.
Could I read what Trump said
please,
just very quickly?
Enlighten us.
This is what Trump said. If they don't start, they won't have a problem. If they do start, it's awfully tough to get off of, Trump told reporters. Then he said, so if we can keep them from going on, and maybe by talking to youth and telling them, no good, really bad for you in every way. But if they don't start, it will never be a problem.
Yes, Nancy Reagan. You got it.
Just say no.
Just say no.
Solution.
Words of wisdom right from our fearless leader.
Yep.
He's got it. I think his son-in-law's in charge, right? So we're all right. All right. Is it that time, Pete?
Yes, sir.
All right. We're going to sail away.
Just say no, Pete.
No, we're not
No,
sailing
we're not sailing away.
away.
We're drifting away into the abyss. All right.
Thank you, everybody.
All right. Good
Thank
night.
you.
Good night, Sullivan. Good night, Thea.
Stay sober.
Stay sober. That's your homework for tonight.
PPRNradio.net. PPRNradio.net. Featured guest DJs. Music news. The hottest DJs from around the world.
It was worth coming up here just for the Sour Patch.
You have Sour Patch Kids?
They're like,
there was no like, hey, I have Sour Patch Kids. Do you
these
want
are like
some?
seriously old. So I'm like taking my life in my hand right now. But if you want to, please. They were sitting here.
Candy, don't go old Sour Patch
They
Kids.
were sitting here. They're not
Sitting here
mine.
the whole time.
Where'd you get them from?
Right there. That's what I
Did you bring them?
No.
Pete, how old are these?
They didn't even know they were there.